Hi everyone, this is Dr. Shivendra, consultant endocrinologist at NHMMI Hospital, Raipur. So I will be discussing an interesting case which I have seen recently. This is a case of Mrs. B.L. Agarwal. She was a 52-year-old lady, housewife with a sedentary lifestyle. She was known to have diabetes, type 2 diabetes since 2012, and she was on glimepiride 2 milligram twice daily and metformin 500 milligram twice daily. She was also hypertensive for last 12 years and was taking amlodipine and hydrochlorothiazide 5 and 12.5 milligram respectively. She did not have a prior acute coronary syndrome, chronic stable angina, any history of stroke, claudication. However, her microvascular complication workup was unknown. She was a non-smoker, but she had a history of premature coronary artery disease, and she presented in emergency department with acute coronary syndrome, diagnosed as a case of acute ST elevation myocardial infarction. She came in window period, and she straight away underwent coronary angiogram, which showed a double vessel disease, a calcified left main coronary artery disease, a triple vessel disease with predominantly involving left anterior descending artery. She underwent primary PCI in left anterior descending artery and a balloon angioplasty in a D1 branch. And at that point of time, her echocardiogram showed a 41% of ejection fraction with regional wall motion abnormalities in anterior wall. She was obese with weight of 89 kgs and a BMI came out as 31 kilogram per meter square. She was hypertensive at presentation and tachycardia was there. At baseline, at presentation, her HbA1c was 8.9%, random blood glucose was 311, creatinine was normal, liver function tests were okay. She had mild hyponatremia, probably secondary to dilutional hyponatremia, secondary to left ventricular failure. Her lipid profile was deranged with LDL cholesterol being 131 and her NT-proBNP was high. So suggestive of she also presented with acute left ventricular failure along with myocardial infarction. So what are the challenges we had during for this patient at presentation? She presented with acute myocardial infarction. She was hypertensive. She had uncontrolled glucose levels with A1C of 8.9. She was obese and sedentary. But what about microvascular complications? We needed to check. So considering all these baseline history, what is the risk status for this patient? Of course, she came into a very high risk patient considering a recent myocardial infarction. So there is established atherosclerotic cardiovascular disease. Plus there was a strong family history of premature CAD. The comorbidities of obesity, sedentary lifestyle and hypertension was adding up to the risk. So she was kept at a very high risk patient for future cardiovascular events. Along with, she also had high A1C levels and she was sedentary. So we need to look up into the other ways to comprehensively plan the treatment. So during the hospital stay, because of the high glucose levels and the planned procedure, she was kept on an insulin infusion for first 2 days. Then she was shifted to the basal insulin, a glargine was used, and the prandial insulin, aspart insulin was used. And at discharge, her glucose levels came fairly okay with fasting of around 134 and postprandial of 186. At this point, she was given a basal insulin of glargine 16 units at bedtime, along with metformin started at 500 milligram twice daily. Linagliptin was also added at 5 milligram once daily. She was also on dual antiplatelets at orvastatin 80 milligram. Of course, that has to be given post-MI along with metoprolol, ramipril and spironolactone. 1 week later, which is the usual protocol at our setup to follow up the patient after 1 week, her fasting glucose levels were still on a higher side, being around 120 to 140 milligram per deciliter, and the postprandials were coming around 190 to 200 milligram per deciliters. At this point, she was started on glargine 18 units, which was hiked up because of the high fasting glucose. Metformin was increased to 850 milligram twice daily, and she was this time, instead of linagliptin, she was started on empagliflozin and linagliptin combination of 25 and 5 milligram respectively, once daily. At 3 months, when I just saw recently 2 days back, She had a perfect fasting glucose levels of around 98 to 100 and postprandials of 132 to maximum 155 milligram per deciliter, and HbA1c is perfectly okay at 6.9%, which is the target now for this lady. She doesn't complain of any urinary symptoms, and her echocardiogram latest was done, which showed a 46% of ejection fraction. So there is a increase in the ejection fraction from the previous of 41%. So now with this background, I need to discuss a little bit about the treatment of diabetes in this high-risk patients. So we know that almost 2/3 of patients with diabetes die from coronary artery diseases, almost half from acute coronary syndromes. So we need a better management. In fact, because of the recent advances in the management, there is a recent decrease in the mortality rates, and more so this has been with the newer addition of the drugs. So what we were missing in those times in the previous treatment arms, that we were ignoring chronic kidney disease and heart failure specifically as a risk factor for hospitalization as well as morbidity and mortality. So in 2015, with the outcomes of the IMPERX outcome study, it has been shown that this drug is particularly useful in reducing the heart failure risk by 35%. And in fact, this trial also showed that there was a robust decrease in the cardiovascular death. And remember, this study was done on a high-risk patients who had established atherosclerotic cardiovascular disease, like the patient we have just discussed, and a robust decrease in heart failure hospitalization death. And along with this also showed that there were favorable renal outcomes as well. So with this, we should consider it as a landmark study, because SGLT2 inhibitors laid the foundation for the future treatment for diabetes. And now we are more centric towards not the glucose levels only, but also the cardiac benefits and renal benefits we are also considering while we are prescribing the anti-diabetic medications. And with the results coming up with the Emperor Reduce, which has shown that even in reduced ejection fraction on non-diabetic subjects, these drugs are helpful. There have been sub-analysis from EMPERX study, and which has shown that new onset of worsening nephropathy is also decreased, which we have already discussed. Now, a little bit about the linagliptin, because this drug has been in the market for quite a long time. It has a unique profile. It has primarily non-renal but hepatobiliary route of elimination. So definitely it does not require to be reduced in CKD patients. And with the recent Carmelina study being conducted, it has been found to be non-inferior. So it is quite safe, cardiovascular safe, along with a slight reduction of albuminuria being found. So this is possible that once we use a combination of these two drugs, SGLT2 inhibitors and linagliptin, so we can have a much more benefit in terms of HbA1c reduction. There may be a hypothetical further decrease in the albuminuria risk, as shown with the Carmelina study. And some recent studies have suggested, both the observational studies and the randomized studies, that this combination probably has better outcomes in terms of reduced risk of genital infection. So probably this drug has a future. We can use it more and more in our upcoming patients, with the benefit that they reduce the pill burden, they reduce the cost also when given in combination, and probably had better HbA1c reduction, good cardiac and renal benefits, along with maybe slightly lower risk of genital infections. So this was from my side. Thank you.